I'm Joe Halco, Director of Community Relations for Northwestern Counseling and Support Services, and welcome to another episode of NCSS Here for You. Since 1958, Northwestern Counseling and Support Services has been providing access to high-quality services which promote healthy living and emotional well-being to the residents of Franklin and Grand Isle counties. Over the years, as the needs of the community have changed, so too have the programs and services that we make available to assist children, adolescents, adults, families, and seniors. We take our role in the community seriously and strive to provide a continuum of the highest quality services to meet the needs of individuals who seek assistance at any point in their lifetime. This month's episode is titled NCSS Integrating Suicide-Focused Care in Primary and Specialty Care. During 2017, which is our most recent data, 112 Vermonters died by suicide, which means, on average, someone dies by suicide in our state every 3 days. Suicide is also the second leading cause of death for Vermonters aged 15 to 34. What are the risk factors? Are there programs and services available for individuals that are struggling with suicidal thoughts? Today we'll discuss how NCSS integrated health team members embedded within primary and specialty care practices are reducing the stigma of mental health and providing suicide-focused care. And now I'm pleased to introduce this month's guests, and they are Dina Chase, NCSS Integrated Health Program Manager, and Catherine Marin, NCSS Integrated Health Team Leader. And I'd like to welcome both of you to the program this month.
Thank you, Joe.
So let's begin with, what is integrated healthcare?
Yeah, so I think of behavioral health integration really as care delivery where a patient or an individual can receive both their physical health care and wellness and their emotional or mental health care in the same setting. And in this case, we're talking about primary care and specialty care settings. So as you know, we're a part of the designated agency Joe just mentioned, and designated agencies across the state have follow a master agreement through the Department of Mental Health as well as the Agency of Human Services, in which certain services are expected to be delivered. And then there are other services. As Joe mentioned, we take our role very seriously, so we look in the community to identify gaps of service areas, and we try to fulfill those gaps with other services that are not necessarily mandated or expected of us, but just because we know that's what our community needs. And so behavioral health integration started about 9 years ago. We're lucky enough to partner with the Blueprint for Health as well as our federally qualified health center in our area called The Notch. And we hire the majority of the social workers that are embedded in primary care and specialty care settings. And these social workers provide mental health services, they provide care coordination, they identify needs of patients in real time and are able to many times address those issues right in that same appointment. Someone might come in and present with their provider with. And are there things I'm forgetting, Catherine?
Yeah, I think that we provide support for mental health needs as well as care coordination to resources in the community, connections to other community partners, as well as provide some assessments for the primary care providers as well as diagnosis.
Yeah. And consultation, like Catherine said, consultation to the primary care providers. So if they're in with a patient, they may come out and either introduce us to that patient or the staff to that patient, or they may just ask for some insights from the staff and continue their meeting with their patient.
Yeah, we're really at the table with the primary care team, working directly and a part of the team embedded at the practices.
So Why provide suicide prevention treatment in primary care settings?
Well, one thing that we know for sure is that 45% of individuals that have died by suicide have seen their primary care provider within the last 30 days prior to their death. And we also know that that percentage is significantly higher for individuals who are older, elderly individuals. So it's extremely important to provide this service and have it available right in primary care.
Mhm.
And
There's a unique access point for prevention and intervention.
Mhm.
so, is there a particular treatment model that you use?
Yeah, so as part of the Zero Suicide effort through the state of Vermont, NCSS was afforded the opportunity to have staff trained in what we call CAMS, but it's the Collaborative Assessment and Management of Suicide Screening and Treatment Protocol, evidence-based treatment protocol. So we started doing that back in 2014. We're currently on our 7th cohort of staff being trained in the model. And so that's agency-wide, not just our clinicians in primary care. We decided, early on that it was pretty essential to having the staff embedded at our patient-centered medical homes, our primary care offices, to help kind of ease access to care. So really that unique access point to mental health services. So really what that looks like is really step one is early identification of the risk. So what that means is a patient presents to their wellness exam or to their physical, and they might disclose to their primary care provider that they're depressed or they're having suicidal ideation. And so that triggers a warm handoff, what we call it, our direct connection to the mental health clinician embedded at the practice to continue assessing, and then pulling in other resources as needed, are continuing treatment. So there's some safety planning involved, accessing other resources in the community, and then ongoing clinical tracking of suicide status. And so it really gives the clinicians and the patient a structured model to follow for treatment.
And how does NCSS provide the suicide prevention treatment in these primary care settings?
So how we, as I mentioned, just, there's that warm handoff from the primary care provider to the clinician. First, they kind of provide an assessment to see kind of where their risk scoring is at, and clinically decide if, they get our crisis services involved or our mobile outreach services involved, and maybe continue doing safety planning with the patient as well as maybe the patient's family. And then there's a structured kind of step process to continue the treatment. So scheduling the next patient visit, having a plan if the patient doesn't present to the appointment or no shows. So it really allows for a structured plan of action for the clinician and the patient.
Yeah, and Catherine mentioned some other teams at NCSS that may or may not get involved. And as an organization, we've worked really hard to kind of systematize the way that we use CAMS and make sure that everyone knows what other teams are doing as well. And so as a provider in a primary care office, we know that it can kind of feel a little bit lonely because we're the only social worker there, or that person may be the only social worker there, but we always have the backing of the rest of our teams at NCSS. We're part of a greater system of care, and we know that we can always call our crisis team, and they're extremely responsive and helpful, and we can always reach out to mobile outreach team, which sometimes can bridge the gap of services for these individuals that may be presenting with suicidal ideation. Let's say it's a weekend and they just really need some check-in calls. They really feel they would benefit from someone calling them daily. The mobile outreach team has been very gracious and has done that quite often for several of our patients. And that can be a huge intervention for what the patient is needing at that time.
Yeah.
And then we would move on to developing a more detailed treatment plan for the individual, but sometimes that's what they need just for that day or that weekend or that evening.
Yeah, it really allows us to have a concrete screening process, and then that can further, allow us to, clinically assess what the next kind of move is. And so it allows us to kind of bridge the support each step of the way. And so we have a real collaborative approach to that.
So why is CAMS important?
So I think from our perspective, it is, again, that, echoing what we've said, that really structured evidence-based protocol that really identifies the drivers for suicide and really gives us the language to talk about suicide confidently and kind of taking some of the stigma out of it. And it also is something that's done collaboratively with the clinician and the patient, rather than giving somebody a screener to take and check off themselves. They're sitting with the clinician, or right now it's via Zoom, but they're really doing it together and walking through each step of the process together and really processing each part of this screening tool. So it's this collaborative approach, and it's like an aha moment for the clinician and the patient, kind of going through it together and really identifying what makes them feel suicidal, what makes them want to die, and how do we find their protective factors. So it really,
sorry, Catherine.
No, just gives it some context.
Yeah, I was going to add to that just that there have been times when identifying the reasons for living can be really helpful, and that's the specific language that is used on the form. And it can be very helpful sometimes for patients. Sometimes they're really able to identify what those are, and we're able to help them hang on to that and move forward in their treatment. And oftentimes we'll find that the score of really wanting to die isn't as high as the patient or we thought it was. And we can really dig into more of the drivers that are giving them that feeling of maybe suicide is an option. And oftentimes it's around pain individuals are feeling, deep emotional pain, and feeling alone with that deep emotional pain.
So, we're really talking about the importance of screening that takes place at primary and specialty care practices for depression and what this can do.
Yeah, and I can't really stress how important that is. I mean, certainly providers can meet with an individual patient and based on their assessment can refer to us very easily and give us a warm handoff. But that systematic approach to screening is what ensures that we will reach all the individuals that need our help and not just the ones that came in that, for a specific cold that day. But if we do systematic universal screening, which is what we're striving towards for depression, and we have protocols in place where if the score of that screening is over a certain number, or if the particular question that is the suicide identified question is endorsed, that is an automatic, what we call an automatic WHO or an automatic warm handoff to the social worker in that office. And then they can meet that person in real time and really help assess what's happening. And as Catherine talked about, really dig in deeper, develop a treatment protocol, make the referrals that are necessary, support the person through that day, that evening, and get resources involved. Sometimes it includes getting family involved, especially in our pediatric office, getting parents and or caregivers involved with the treatment. We always have one of our staff who worked in pediatrics for years. I remember her always saying that she would have the youth take a photo of their oh boy, what's the word?
Plan.
Stabilization. I always want to say a different word, but the stabilization plan. She would always have them take a photo of it with their phone, because 9 times out of 10 they had a phone, so that they would have that right to look at right on their phone.
Mm-hmm. Yeah, I feel it's really a collaborative approach to treatment that people really appreciate, in my experience.
You know, and another thing about being embedded in primary and specialty care practices is this reduction of the stigma of mental health. So I think what's important for us to take a look at here is the fact that in the days where our staff were not embedded in these practices, people would get referrals to NCSS. And as we all know, the number of referrals who actually took the step was rather limited. So if you could speak to how critical it is by being embedded in these practices, that you're also helping to destigmatize mental health as well in working hand in hand with physical health.
Yeah, you know, we track our data, and I think last year we had over 300 people that had never accessed mental health treatment ever in their lifetime, and accessed it through us in primary care. And so that number was really like eye-opening for us as a team, because we know that an individual might know that they want therapy, need therapy, but that step getting out into the community is just not accessible for so many reasons. And us being right there to provide that support and really kind of triage the appropriate level of care helps reduce maybe their anxiety or their stigma around getting mental health treatment, as well as, you know, the culture of the medical community. So really,
And
we're there.
that, sorry, I was just going to add, in having that trusting relationship with their provider. Hopefully they do. And we know that that goes a long way, to hear from your provider or your practitioner that you work with for your primary care to say, listen, I have someone on my team that I work with every day that I trust, that really works on these issues of anxiety and depression that you're talking to me about. And I'd love it if I could introduce you to them today, or I'm going to go get them and bring them into your appointment and introduce you to them. So that endorsement for us goes a long way for individuals following through and coming back and seeing us again.
Yeah, it's really I feel like a more holistic approach, a whole body approach, you know, that it's not separate. Physical and mental health aren't separate. We know that now, you know, and so we're just part of the flow, you know, that mental health is part of your wellness, and it's not something you need to go to a building, you know, down the street. It's something that you can access right here and bridge that connection. I think another thing, you know, that we try to do is kind of shift the language used around mental health within primary care, within the medical community, and how you know, to kind of support a more person-centered approach to, you know, maybe symptomology that is a little more challenging or difficult to understand. You know, so that's where we step in and we say, hey, you know what, we've got this. We can handle this. We know how to support this individual, because that's what we're trained to do.
Yeah, there's no question that this model of having NCSS staff embedded, when you say, Catherine, over 300 people who had never sought mental health assistance in the past, and you take that and expand that out over 5 years or 10 years, because we know that so many people don't seek mental health treatment to begin with. We also know that there are so many who wait 5 or 10 years before finally taking the step. And had they have taken the step a lot earlier, it would have been perhaps easier for them to, deal with their struggles had they have had treatments well in advance. So I think the fact that all of you are doing the work you are in these primary and specialty care practices is fantastic. And as you said, Catherine, the mental and physical being linked together truly is the way to a holistic approach that people have to take. They have to understand that there is a linkage there, and it is not as if the brain is separate from the rest of the body. So with all that being said, can you share an example of how this situation might unfold?
Sure. So an individual can, come to a visit at the clinics. So can be, I use the example of a wellness exam or a physical, but it could be somebody coming in for strep throat. I've seen warm handoffs for all different types of situations where something just kind of unfolds with the provider and the individual, and they disclose that they're feeling depressed or they have thoughts of self-harm or ongoing suicidal ideation. And so that's that automatic connection to me. So what's nice technology is they, send me a little message, and I go in and I introduce myself, I explain who I am, and or any of the clinicians do, and how, this is a systematic approach that we use to help assess people that are feeling, this way. And so depending on that conversation and kind of the direction it takes, there's kind of the next steps. And so if the clinician assessed that this person might, be in danger or be at risk for harming themselves, then we kind of triage things appropriately. So that's one thing that I found really pretty incredible is calling crisis together. So with the individual on speakerphone, calling our wonderful crisis team, and just really bridging that connection there so that they have a real person. It's not just like, here's the phone number, call them if you need them. It's like, hey, here's X, Y, and Z. They're available 24 hours a day. And so that's been a really empowering part of the process. And so you kind of, you set the person up for when they leave, kind of, with that stabilization plan. So if it's connecting with crisis, if it's referring to our mobile outreach team so that they can do calls throughout the weekend, and then deciding on kind of your level of treatment. If you start engaging with them in therapy within the primary care office, maybe for a few sessions, and deciding that long-term treatment is appropriate, then doing that, or continuing to do therapy and utilizing the model in primary care. Dina, if you wanted to add anything.
I think you got it.
Yeah. So it really gives us, I think, the clinicians some peace of mind of having this to utilize, because it is such a challenging topic, and we kind of bring it out into the open and say, okay, let's address this, and let's find a way to support. So yeah,
I mean, I think it's the work that you both do and your team does is fabulous. Really is. And when you think of 300 people, and like I said, if you just extrapolate that out, how many people are going to receive assistance that would not have in the past is just fantastic. So with all
and I just want to say that, give all the kudos to our team. I know Catherine feels the same way, but they're really dedicated to this community, to their patients, and they do really amazing work every day.
Mm-hmm.
So with everything that we've shared today, one thing that I would like to leave the viewer with is if they or anyone they know needs help, what are some of the resources that are available for them to have as points of contact?
Sure. I believe we're going to put up a slide too at the end with some other numbers, but specifically in the Franklin and Grand Isle County area, for any mental health crisis, an individual could call our crisis line, which is 802-524-6554, and then press 1. And then also of note is that our crisis team does take the calls for the national suicide hotline. And so that is just of note. If someone were to call the national line, they would receive a response from our crisis team. There are several other numbers, and even the Text Vermont line that's going to be put up on a slide. And I encourage people to take these down and really share them with anybody that you might know that's in need.
Yep. And also knowing that we're at your doctor's office. So I think a lot of people don't know that. And so if you need any sort of mental health support or care coordination, just pick up the phone and call them, and you can get an appointment with us fairly quickly. So.
Okay. Well, I want to thank my guests, Dina Chase and Catherine Marin, for sharing their insights about NCSS suicide prevention efforts in primary and specialty care practices throughout the year. I also want to thank you, the viewer, for spending time with us again this month. You can learn more about all the NCSS programs and services by logging on to ncssinc.org. I'm Joe Helko, and I'll be back next month with another episode of NCSS Here for You.